and I'll let everyone in. We have 48 right now.
Perfect.
Welcome, welcome, welcome in. Welcome everyone to Care Concierge with Carepatrol, where education is the heart of everything we do. We appreciate what you do on a daily basis as clinicians in each of your respective areas and jobs. And we appreciate the fact that you invest in yourselves and in those clients by doing additional education like today's session. If you're new to Carepatrol, you can think of us a little bit as a sort of a healthcare realtor. So we work with clients to understand what their options are, where those options are located, if they're a place or if they're simply a service. We help them understand which providers are known to be the best that we vetted, and then we share that information with them. If the information includes moving into a community, we drive them around like a realtor. And at no time do we ever charge them. We're paid by the providers in our network so that our services remain free to our clients, just as this CEU is free to you. We are accredited by the Alabama Board of Nursing. We're also accredited by the Alabama Board of Social Work. And each of those boards allows us to provide 1.0 contact hour for today's session. In order to receive a contact hour, you must complete an online evaluation. I've posted the online evaluation link in the chat room for you, and I'll read it now for those of you that are participating by phone or at your desk but not looking at your screen. If you want to make note of today's password, or excuse me, today's login for the online survey, which you must complete, it is https colon // www.surveymonkey.com /lowercase r / all uppercase letters with numbers 5 3 D as in David X R Y H as in Harry. That's our online evaluation. You must complete it to receive the 1.0 contact hour. Today is a clinical hour, and we're very happy to have a new presenter with us, a lifelong learner who is a fellow at the UAB Neurological Movement Disorders Clinic, Dr. Katlyn Roginsky, who has long been interested in medicine and was led to do her fellowship at UAB due to the great reputation of its staff and faculty across the movement disorders spectrum in healthcare in the U.S. So we're very happy that she's joined us here in the South, and we'll miss her when she returns home to work. But I know that you'll find today's education extremely beneficial. Someone did ask to hear the last part of the password or the online evaluation, rather the password we give at the end. The last part of the evaluation is R / 5 3 D as in David X R Y H. I've posted it again in the chat room. And Dr. Roginsky, I will cease taking up everyone's time and present the floor to you. Thank you again so much for being here, and we look forward to learning with you today.
Hi, everyone. As Sean said, I'm one of the PGY5, next week PGY6 Movement Disorders Fellows at the University of Alabama at Birmingham. I'm pretty relaxed, so if you guys want to put questions in the chat, we can take a pause and do questions, or we can do them at the end, whatever works for y'all. But we'll go ahead and get started. So this is going to be on Parkinson's. Um, in terms of learning objectives, the goals are to understand the pathology of Parkinson's, to become familiar with the clinical presentation and diagnostic criteria, as well as to know and understand the common treatment options, including their indications, uses, and potential side effects. So to start with just a little bit of the background of Parkinson's disease. So Parkinson's has been around a long time. If you go as far back as like 2000 BC, there were some brief descriptions of Parkinson's-like symptoms that presented in many ancient texts, none of them particularly medicine related, but Parkinson's-like symptoms have been described as early as 2000 BC. As we move forward a little bit in time, around 169 AD, Galen was the first that distinguished between a resting tremor and an intentional tremor, which we'll talk a little bit more about as we get into the signs and symptoms of Parkinson's. And then from there, we kind of had a couple more descriptions of what Parkinson's looked like, without having the name Parkinson's, or really a distinct name for the symptoms of Parkinson's as a distinct entity. Moving forward, James Parkinson is the man who's been attributed with the first written description of Parkinson's disease, and that was in 1817 when he wrote an essay on the shaking palsy. This details 6 patients, some of them in passing, some of them he kind of followed for a long period of time. So one patient he kind of had this longitudinal relationship with and kind of wrote the time course of their symptoms, whereas there are 2 patients that he describes here that he met in passing on the streets of London, and one patient that he had never actually talked to that he just saw on the street that he described in this essay. Back in 1817, when he first described the symptoms of Parkinson's and kind of put it together as a distinct clinical entity, he referred to the disease as paralysis agitans. As you move forward through the 1800s, that description became a little bit less of the correct nomenclature as they started to see more and more patients with this kind of distinct clinical entity that they were referring to as paralysis agitans. They noticed a couple of things. One, that the initial description of this like decreased muscular power, decreased muscular movement owing to the word paralysis is not actually true in Parkinson's patients. They don't have any weakness or decreased muscular power. So that part of the word, the title kind of fell apart. And then this agitans, they used to refer to that as shaking. And as more and more patients, and this became more and more recognized by the medical community, they realized that tremor doesn't have to be a necessary component of the disease. And therefore, they did away with that name completely. And then Dr. Charcot, who is attributed to many things in medicine, he was the first to suggest changing the name from paralysis agitans to Parkinson's disease, and that was in 1879. Since then, it's been referred to as Parkinson's disease. So looking more at the incidence, prevalence, and mortality of Parkinson's. So the demographics, your typical patients are going to be older, generally speaking, with a peak age of onset around 60. Although Parkinson's and Parkinson's symptoms can occur at any age, there is a distinct clinical entity that we call young onset Parkinson's disease, and these are patients that have had symptoms starting before the age of 50, and those can be very young. There are patients who have Parkinson's symptoms in their 30s, 40s, and then, of course, which we'll touch on a little bit later, sometimes it's not Parkinson's disease, but Parkinsonism caused by something else. And those patients can run the gamut of any age. The likelihood of developing Parkinson's is going to increase with age. Aside and above all other risk factors for developing Parkinson's, age is the leading contributor to the development of Parkinson's disease. The lifetime risk of developing Parkinson's is about 1 in 15. If a patient has a positive family history of Parkinson's, the risk for developing Parkinson's doubles, and that risk goes from about 2% in the average aging population to 4% in those patients. There have been a lot of studies trying to define discretely the etiology of Parkinson's, and some twin studies that we've done in the past indicate that Parkinson's within that young onset category, so those people under 50, are more likely to have some type of genetic component that predisposed them or caused the Parkinson's symptoms. And it does have a slight male preponderance with a male to female ratio of 3 to 2. The incidence, so incident rates vary pretty significantly based on population studied, but the average is about 11 to 12.9 per 100,000 population per year. And that's across all countries, all continents. It is observed in all countries, all ethnic groups, and all socioeconomic classes, although the incidence in the African American population is lower than that in the Caucasian American population, as well as like Caucasian European population, so on and so forth. There is this kind of lean towards a slightly increased incidence in rural areas compared to urban areas, but it doesn't hold true time and time again over different kind of population-based studies. There's that increased incidence isn't always necessarily true. Sometimes we think that these rural communities, they have more exposure to some of the toxic components we know can lead or contribute to the development of Parkinson's, like paraquat, rotenone, these kinds of things. So they think that maybe that's why that incidence is a little bit increased in rural populations. But again, it doesn't always hold true and it doesn't shake out that way.
Well, we have a question, Dr. Roginsky.
Mm-hmm.
Jennifer Calder asked, does alcohol use disorder, substance use disorder contribute to prevalence?
Not really, aside from, I guess, if you want to consider this a substance, this is probably the only medical condition known to mankind where tobacco use and nicotine is a preventive factor or a protective factor from developing Parkinson's. So we see that people who have a history of nicotine use over time and across multiple different prevalent studies, they have a decreased likelihood of developing Parkinson's disease, although it's not 100% protective. But there's no clear correlation with like alcohol use or other substance use and Parkinson's. And then, like I said, advancing age is the single greatest risk factor for developing sporadic Parkinson's or idiopathic Parkinson's. And Parkinson's as a whole is considered the fastest growing of all the neurologic diseases known currently. Mortality rates. So mortality is kind of interesting. Prior to the development of carbidopa levodopa, which is kind of the backbone of treating Parkinson's, and we'll talk about that later, there was a 3-fold greater mortality in Parkinson's patients compared to age-matched controls. But once levodopa was developed and became readily available to patients, that reduced to a 1.6-fold greater mortality rate in Parkinson's patients compared to their age-matched controls. Most of the times, death in Parkinson's is not actually related to having Parkinson's itself. It's typically related to some type of concurrent but unrelated illness, like a subdural hemorrhage, pneumonia, all the other things that can cause death, sepsis. But when it is related to the Parkinson's itself, it tends to be related to the effects of the patient's decreased mobility, their aspiration risk, and falls with subsequent physical injuries like hip fractures, brain hemorrhages, those kinds of things that can all lead to mortality. All right, so moving on a little bit to the pathology and pathogenesis. So there's a lot of research that goes into Parkinson's every year. A lot of research dollars go into Parkinson's. And despite all of that, we don't quite fully understand Parkinson's disease. I think some of that owes to the fact that we don't quite fully understand the brain in general. And there's a lot of things that develop over time, new studies, new populations, and we start to understand things more and more. But we have a general framework for the pathology and pathogenesis of Parkinson's, and that's what I'll talk about here. So when you look at the macroscopic pathology in Parkinson's, you see this loss of pigmented cells in the substantia nigra, and that's kind of the buzzword when we talk about it in medicine, when we sit for our board exams, those kinds of things. The hallmark pathologic characteristic in Parkinson's is this loss of pigmented cells in the substantia nigra. But looking further, you can also see that there's loss of pigmented cells in some of the other pigmented nuclei, like the locus coeruleus and the dorsal motor nucleus of the vagus. The image off to the right is kind of the prototypical image that you'll see when you're talking about Parkinson's pathology. And so this is the midbrain, which is a part of the brainstem. And then you can see right in here in kind of these like Mickey Mouse ears, that's where the substantia nigra lies. So in the bottom part, that's what the typical substantia nigra would look like. It has some deep colored pigmentation. But as we see in Parkinson's patients, we lose that pigmentation. So those cells are lost for some reason. Studies over time have shown that these substantia nigra cells or the nigral cells diminish with age, no matter what you do. Not completely related to Parkinson's disease. These cells do just die off over time. They diminish with age. But patients that have Parkinson's are at 30% or less of the total cell population compared to their age-matched controls. So really, when you see patients with Parkinson's, patients that have symptomatic Parkinson's, you know that these the nigral cells are already at 30% of the population or below, which is a pretty significant reduction in cells to not have symptoms really much before that. Microscopically, this is also kind of pathognomonic a little bit for the disease, is that the pigmented nuclei are going to show marked depletion of cells. So we talked about that. That's why it loses that coloration macroscopically. But also those cells are replaced by gliosis. Gliosis is a similar process to what you see in stroke. As the cells are damaged, they die off and they're kind of replaced by scar tissue, for lack of a better term. And that's what gliosis is in the brain. Some of the remaining cells have a reduced quantity of melanin. So just like melanin is found in our skin, it's also found in our brain cells, heart cells, all of our cells really. So some of the cells that do remain have reduced quantities of melanin, again, leading to that depigmentation. And then the majority of the remaining cells are going to have this eosinophilic or very pink cytoplasmic inclusion that's surrounded by a little bit of a faint halo, and that's called a Lewy body. And so that's what you see here in this picture off to the right is the Lewy body. It's this kind of starkly pink area with lighter pink around it. That's pretty pathognomonic for a Lewy body type disease. So either Parkinson's disease or Lewy body dementia, you're going to see this kind of feature on microscopic pathology. And then looking a little bit into the genetics of Parkinson's, this is kind of a hot topic in Parkinson's in general, is that are there genes out there that contribute to the development of Parkinson's or ultimately cause Parkinson's? And there's active research in this field. One of the active research studies that is recruiting here at UAB is called PD generation. And this is a study that looks distinctly at some of these genetic parts of Parkinson's to see if our patients have them or don't have them. So kind of on this graph, I know there's a lot going on and a lot of colors and a lot of letters that don't mean a lot, but there's a subset of genes that we know cause the disease. So these are things like our LRRK2 mutation, which is one of the kind of more popularly studied, although very rare mutations to see in general, but like LRRK2, that's a big one. This PARK2, PINK1, all of these are known to cause the Parkinson's disease, but are very rare. Whereas when you look at these other more common things like SNCA and LRRK2 can also fit into this, but MAPT. These are very, very common genes that we see in Parkinson's patients, but we know that their risk to some extent is much lower. And so you're looking at, like in LRRK2, there's specific mutations that are more common but have a lower risk of conferring disease, whereas there are certain mutations that are very rare but have a higher incidence of causing Parkinson's disease itself. And these are all a little bit different. For the vast majority of these mutations, they're kind of a 50-50 mix of whether they're autosomal dominant in inheritance, meaning there's a 50% chance you could pass it on, versus autosomal recessive, which kind of boils down to a 25% chance that any child could develop or receive the mutant gene and then develop disease. And so they're kind of all over the place. But we do know that these genetic conditions, patients tend to be younger in onset. So looking more into the 30s and 40s, sometimes down even into the 20s for development of Parkinson's symptoms and then ultimately diagnosis of Parkinson's disease. There are very few that are more late onset Parkinson's or more traditional Parkinson's when they're inherited. All right. So looking at the actual etiology of Parkinson's, and like I said, this is kind of not 100% well understood. But this is kind of the arena that we're in now, and this is kind of how we describe things to patients. So we think that Parkinson's is complex. It's not quite as simple as some other diseases where if you have a mutated gene, then you're going to get the disease, or you have the risk of passing the disease on to your children, so on and so forth. But we think Parkinson's is a lot more complex. It's an interplay of, do you have genes that may predispose you to developing Parkinson's or even cause Parkinson's, in combination with things like environmental toxins like paraquat, rotenone, DDT, other organophosphates, these kinds of things that have been shown in multiple studies to be associated with the development of Parkinson's disease, but also these endogenous factors. So factors intrinsic to you that aren't necessarily genetics that can also contribute to the development of Parkinson's. That leads to the pathogenesis, and then that pathogenesis we're seeing is increasingly more complex, a lot more complex than we thought it was. It involves things like protein aggregation, oxidative stress, mitochondrial stress, inflammation, and then ultimately apoptosis and parthenosis of the cells themselves, ultimately leading to the phenotype of what we see as Parkinson's disease. As we do more research in the realm of Parkinson's, we see that it's increasingly more complex. It's not as simple as these cells die off. It's these cells die off and this is happening, and there's a lot of oxidative stress in the brain and the mitochondria don't function well, so on and so forth. And that's why the etiology of Parkinson's is just not as well understood as some other diseases. All right, kind of the hot topic for a clinical based discussion is the clinical features of Parkinson's disease. So, a general overview, and I kind of alluded to this in the beginning of the talk, is that Parkinsonism is the syndrome of rest tremor, bradykinesia, rigidity, and postural instability. When we learn it in med school, they tell us that the mnemonic is TRAP, so tremor, rigidity, akinesia or bradykinesia, and postural instability. When a patient has all of these in combination, some to varying degrees, maybe some more tremor, less bradykinesia, so on and so forth, that puts them in the bucket of Parkinsonism. Parkinson's disease is one form of Parkinsonism, but it's not the only form of Parkinsonism that exists. This also includes things like our atypical Parkinsonian syndromes, which we won't talk about today, like multiple system atrophy, corticobasal degeneration, and progressive supranuclear palsy, but also things that can secondarily cause Parkinsonism, like vascular Parkinsonism, which is from extensive like vascular changes in the brain, metabolic things, and genetic conditions like Farr disease, Wilson disease. Also, drug-induced Parkinsonism can fit into this category. And so there's a lot of things that can lead to Parkinsonism, and Parkinson's disease is just one form of that broader bucket category. When you break down Parkinson's symptoms, the cardinal features are the tremor, rigidity, bradykinesia, hypokinesia, akinesia, and the postural instability. And so to look at those a little bit further, the tremor itself is pretty characteristic. It's most pronounced at rest, meaning when the hands are kind of resting, you're not actively using the hands. That's when you have more of this tremor. Over time and in advanced Parkinson's, there can be a little bit of an action or posture component to it. And as we all know, patients don't read the textbook. And so there's no rule that says you can only have Parkinson's. That can be the only contributor to your tremor. And so there are people who have kind of mixed presentations when it comes to tremor. But characteristically, your Parkinsonian tremor is going to be a rest tremor, and it's described as this pill rolling type phenomenon. And that kind of dates back to when our pharmacists had to hand roll pills, and there weren't machines that did this kind of stuff for us. So it looks very similar to how pharmacists used to have to roll pills in the past. Typically, when the tremor first starts, it's unilateral in onset. Again, that's not a rule, but it's kind of a trend. Usually it starts on one side of the body and affects that side before it starts on the other side of the body. The frequency is around 3 to 7 hertz classically, and that's more measured in terms of like in the physiologic testing laboratories when they're hooked up to EMG and that kind of stuff. You can see this 3 to 7 hertz resting tremor. Tremor tends to be the most common presenting symptom, but it doesn't have to be. And there are patients with Parkinson's who have very little to no tremor whatsoever. Typically, it's going to start in the hand as this pill rolling tremor, but over time, it can progress to involve the tongue, the jaw, the lips, legs, and very rarely you can see tremor in the head. But that's pretty uncommon in Parkinson's patients. Parkinson's patients tend to have a fair amount of leg tremor. And when a patient comes in with just complaint of a leg tremor, the differential for what that could be is it's pretty narrow and almost, I would say probably 90% of the times I've seen it in my practice, leg tremor as the only complaint led to a diagnosis of Parkinson's disease. Moving on a little bit to the rigidity. So rigidity and spasticity are two things that kind of go hand in hand that they teach you together. Rigidity is a velocity independent process, whereas spasticity is velocity dependent. So when you talk about rigidity, it's this resistance to passive movement about the joints of a limb that does not depend on the velocity at which you're moving the patient's limb. It's most characteristically, Parkinson's rigidity is characterized as this cogwheel rigidity, where they have this jerky ratcheting type pattern of like muscle resistance, then it relaxes, resists, then relaxes, so on and so forth, kind of like a cog moving in the wheel of the machine. And that's thought to be secondary to rigidity that's superimposed on this picture of tremor. But they don't have to have cogwheel rigidity, they can have any type of rigidity. Lead pipe is where you kind of feel it across the whole movement of the joint all the time. Cogwheel is that jerky component. And there are some patients with Parkinson's that have other things underlying it, and they have a little bit more spasticity than they have rigidity, or a combination of the two. And that's not uncommon or completely unheard of, to be a little bit more spastic than rigid.
Dr. Roginsky, we have a
Yeah.
question. Lisa Hurd asked, has anyone had a misdiagnosis of Parkinson's when it was actually TDK?
Um, I'm not sure, to be honest. I'm sure that there are patients that are misdiagnosed tardive dyskinesia, and or vice versa, they're diagnosed as Parkinson's, but they actually have a tardive dyskinesia. Um, I haven't seen it here in my time at UAB. I would say the more common like misdiagnoses when it comes to tardive syndromes are like patients who have chorea from another cause, either like a benign hereditary chorea or a Huntington's related chorea, but they're diagnosed as a tardive syndrome, so on and so forth. But as we'll talk about later, Parkinson's patients can also become dyskinetic, not only as the disease progresses as part of the disease, but also as a secondary effect of medication. And so I don't think it's necessarily unheard of that the two would be misdiagnosed potentially.
Thank you.
Mm-hmm. All right. And then moving on to the cardinal feature of bradykinesia, hypokinesia, or akinesia. This kind of characterization of slowness or lack of movement is typically the main cause of disability in our Parkinson's patients. They're moving slower, and that affects multiple areas of their life. As you can see, it's not just necessarily what we think of in terms of what we're testing for in the clinic with these rapid alternating movements, typically like finger taps, hand opening and closing, and then hand pronation, supination, either like flipping it back and forth, up and down, or sometimes like asking them to, if they're opening a doorknob. That's what we look for in clinic. But bradykinesia is a lot more than that. It's what causes that hypomimia, or that decreased amount of facial expression. It can also cause a dysarthric type picture where their speech is affected because their voluntary facial muscles don't move as quickly as they want them to. It's what contributes to micrographia, or that small handwriting that kind of tapers off over time. Also, some decreased manual dexterity with fine motor tasks. So a lot of patients will have difficulty like buttoning, zipping, that kind of stuff. But also bradykinesia and hypokinesia is the part of the disease that leads to the shuffling of gait, the gait freezing, the falls, all of these kinds of things that increase disability and ultimately mortality in our Parkinson's patients. When you look at the movements in our Parkinson's patients, they're both slow and reduced in amplitude. So when we have patients do finger taps in the clinic, what we're looking for is this combination of the movement isn't as fast as you want it to be, and over time it gets a little bit slower and a little bit shorter. They can't maintain this whole range of motion. And then we test it clinically with all these rapid alternating movements. So the hand movements, also like foot tapping and foot stomping is a good way to look for bradykinesia and hypokinesia in the extremities. Also, patients can be just globally bradykinetic, meaning they're just much slower to do things than you would expect, like stand up, get out of a chair. But also, when you compare them to other people in the room, like maybe their care partners, their children, whoever comes with them to their clinic visit, they're just generally less fidgety than the average person, the person without Parkinson's disease. They don't move around a lot in their chair. They don't blink a lot. They don't talk with their hands as clearly I do, those kinds of things. And that's all a part of the bradykinesia. And then looking at the postural instability. So in Parkinson's, this is from a loss of postural reflexes, and then they get this sensation of imbalance that then leads to falls. So not every Parkinson's patient is going to be falling, but a lot of them will complain that they feel off balance, or maybe they stumble a little when they turn, or when they first get started, or when they're trying to stand up out of a chair. Sometimes they stand and then fall right back down. In the clinic, we test postural instability with the pool test. And what that is kind of what this picture depicts. It's hard to depict in a pictographic form, but we have the patient stand with their arms relaxed at their side, their feet kind of close together, and we pull back on their shoulders. The average person who doesn't have Parkinson's or some other condition that limits their mobility will be able to catch their balance. Parkinson's patients have a tendency to like take small shuffly steps back, multiple of them, or they can't right themselves at all and they just kind of fall directly into you as though it were a trust fall. So that's the most common way we test this in clinic. But you can also see there are some patients that have such poor balance that when they're walking just down the hallway in clinic or back into the clinic room, that you can see that they're kind of swaying, they're very unstable, unsteady. When you break down Parkinson's disease, this is kind of a busy slide, but this is the truth of Parkinson's disease. The cardinal features, those hallmark features, are all motor symptoms of Parkinson's. But there's a whole slew of non-motor symptoms that sometimes get overlooked, or they're not brought up in the average clinic visit, and they're almost or arguably more important than some of the motor symptoms. So when you talk about motor symptoms, it's most of the stuff that I already reviewed. So the hallmarks being the tremor, bradykinesia, rigidity, and postural instability. The bradykinesia can lead to that hypomimia or decreased facial expression, some slurred speech or difficulty with speech, sometimes difficulty swallowing, resulting in aspiration or episodes of choking, and also with drooling. Right. So there are a vast amount of Parkinson's patients that drool, and it's not because they're producing more saliva than the average person, just that their swallowing muscles and their reflexes are slowed. And so if it's not going back, you're not swallowing it. The only other place is forward. So there are a significant amount of Parkinson's patients that do have some drooling that's bothersome to them. The bradykinesia can also lead to microphagia, meaning they're a lot slower to eat. They take slower bites. It takes them a longer time to do things. And because of that, they eat less and then they lose weight over time. But they can also have difficulty cutting their own food, feeding themselves, like getting their fork or spoon up to their mouth, um, doing things for themselves at home, like dressing, basic hygiene, and other activities of daily living, and or I guess IADLs as well, like medication management, these kind of cooking, all of this stuff. If you're slowed down, you have a lot of tremor, that's going to impair your ability to do these things. Patients also kind of very typically on gait examinations have decreased arm swing. It can happen in both arms, but it tends to be more pronounced on the side that the Parkinson's symptoms started. So the tremor, the rigidity, the decreased arm swing tends to be more pronounced on that side. They have the shuffling gait where they take these tiny little steps, don't really pick their feet much up off the ground. They can also have freezing, meaning when they're walking or turning. Typically, it occurs when turning or first starting to walk, that they are just stuck. It looks like they can't get themselves going. They also can have a fascinating gait. And this is that gait where they're kind of just propelled forward on these tiny little steps where it almost looks like they're running. But they're just taking these tiny little shuffling steps instead of taking long strides that would get them where they're going. And then they also have this kind of like stooped posture where they lean forward, which can all be problematic. In more advanced Parkinson's or maybe more severe forms of the disease. They also can also develop something that we call PISA syndrome, which is exactly what it sounds like, the Leaning Tower of Pisa, where patients are kind of bent over to one side. Or camptocormia is a pretty severe form of that disease. Camptocormia looks like pretty severe scoliosis, but it's related to Parkinson's. Parkinson's patients can also develop other motor symptoms, and these tend to come more so as the disease progresses. Things like dystonia, whether that's in the hand, the foot, the eyelids, causing a blepharospasm. But also prolonged dystonia can cause some skeletal deformities like the camptocormia or some other, sometimes like prolonged dystonia, like in the arm, can cause loss of muscle tone and things like that. That can also lead to skeletal deformities. And all this kind of fits into the motor symptoms. But then you kind of shift gears and you look at the non-motor symptoms of Parkinson's, and they're just as important. So these include, these kind of, I would say, fall into these big categories of behavioral, cognitive, sensory, autonomic, and sleep disorders. So the biggest things behaviorally is patients with Parkinson's, just like anybody else, can have depression and anxiety, but almost more so because when you hearken back to the loss of these pigmented cells, the locus coeruleus is really important in producing some of our neurotransmitters. And so sometimes patients have less serotonin available, less norepinephrine available, these kinds of things, and that contributes to depression and anxiety above and beyond the average patient population. Parkinson's patients also can suffer from this profound apathy where they're not depressed, they're not anxious, they just have this decreased kind of get up and go. They just feel blah about everything, and that can be a part of Parkinson's. Same thing with anhedonia, it's kind of that same feeling. Parkinson's patients can also develop pseudobulbar affect, so that inappropriate laughing or crying when they're not necessarily sad or happy or find something funny. It just happens sporadically from time to time. And Parkinson's patients can just have this profound sense of fatigue. In terms of cognitive problems, just like everything else in Parkinson's, it's kind of a slow down disease. So they can get bradykhrenia, or the slowness to their thought process, where it looks like it's taking them a long time to kind of compute what you're saying and then compute an answer and spit it back out to you. A lot of Parkinson's patients also complain of this tip of the tongue phenomenon, where they know what they want to say, but it's just lost. And then, of course, Parkinson's patients can develop a frank dementia, known as Parkinson's disease with dementia. And so it kind of spans the spectrum. Not every Parkinson's patient is going to go on to develop dementia, but it is a possibility. In terms of sensory things, this is where we look at a little of what we call the prodromal Parkinson symptoms. So things that can happen years before Parkinson symptoms start. And that tends to be a loss of sense of smell. And then because you don't smell well, that's involved in taste, a loss or decreased sense of taste. So that anosmia and ageusia, those tend to be prodromal. They can also have some issues with their visual acuity, contrast, and color sensitivity. Very rarely, patients can have paresthesias, but actually more commonly than we think, Parkinson's patients can have pain, whether that's related to their motor symptoms like the dystonic posturing or things like that, or just pain in general. There is a such thing known as central pain in Parkinson's, and it's just a syndrome of pain that's very difficult to treat. In terms of autonomic symptoms, patients can develop a profound orthostatic hypotension. This sometimes leads to episodes of syncope or loss of consciousness. Constipation tends to be a huge problem in our Parkinson's patients, and that constipation also fits into that prodromal feature where sometimes patients have constipation for years before they develop Parkinson's symptoms. They can also have urinary and sexual dysfunction, some abnormal swelling. A lot of Parkinson's patients actually suffer from seborrheic keratosis, that kind of dry, flaky skin due to the dysautonomia. They can also have a lot of rhinorrhea, or like runny nose for no reason, and then some weight loss, although that maybe isn't necessarily related to the dysautonomia as much as it is to their like decreased ability to feed themselves, the slowness. And then when you lose your sense of taste and smell and nothing smells good or tastes good, what's the point situation? And so patients can have a lot of weight loss.
We have
And
a
then, of course,
question.
yeah.
Uh, let's see. Janet Michelle Birchfield is asking, I have a similar question. Reading this slide makes me wonder if it has been noticed that there has been misdiagnosis between MG and Parkinson's. I've never realized there are a lot of similarities.
Yeah, there are a lot of similarities. I would say It's not uncommon. I'm sure it's happened. But the one big differentiation is that even though Parkinson's patients are slow to move, maybe it takes them a longer time to achieve complete muscle activation, their strength is pretty fairly preserved. When Parkinson's patients lose their strength, it's usually like a disuse problem. So they're not getting up, they're not moving around, they're not walking as much, their legs get weaker, so on and so forth. That tends to be the most common problem in terms of weakness related to Parkinson's disease. Whereas myasthenic patients, they just have this organic weakness because of the disease process. So they have weakness more in their proximal muscles like shoulders, their bulbar muscles with difficulty swallowing, eyelids. They have a hard time like opening their eyes, that kind of stuff. So it's more of an actual weakness. And on like when you go into kind of secondary measures and how to work up these things, myasthenic patients will have abnormal EMG and Parkinson's patients should have a normal EMG because they have no like muscle weakness or fatigability. But they do sound a lot alike, especially with this dysautonomia and things like that. All right. And then the last kind of non-motor set of symptoms is sleep disorders. So I think the biggest thing here is REM sleep behavior disorder. Again, this is one of those things that can actually be a prodromal symptom of Parkinson's. So these patients who act out their dreams at night. And it's not yes necessarily just like talking or yelling. These patients can get very aggressive at night, like punching, kicking, screaming, getting themselves out of bed. And this leads to one, not only injury to themselves, if they get out of bed and they slip and fall, those kinds of things, they can hurt themselves. But also when you're acting out your dreams, punching, kicking, you can hurt your bed partners. So that's not uncommon in Parkinson's patients. They also can report vivid dreams, nightmares more frequently than the average population. They can have a significant degree of daytime drowsiness, also sleep fragmentation, where they're not getting great quality sleep overnight. And some patients with Parkinson's do have restless leg type symptoms or restless leg syndrome in general. All right. So when you look more towards that's the clinical picture of Parkinson's, how do we make the diagnosis of Parkinson's? Well, it's pretty simple and not simple at the same time, and that Parkinson's remains a clinical diagnosis. So there's no single blood test, image scan, anything that you can do that definitively says you have Parkinson's and nothing else, but there are some things that can help us. Parkinson's tends to be asymmetric, affecting one side of the body much more or only one side of the body than the other side. And so sometimes it would be worthwhile to get just a standard run of the mill MRI to rule out structural lesions that can mimic a Parkinson's type picture, like tumor or stroke being a big one. So sometimes that conventional MRI can be helpful, but again, in idiopathic Parkinson's disease, nothing specifically on the MRI is going to point you to that diagnosis of Parkinson's. And then kind of some confirmatory testing or things that can help along your trajectory. There's two big things available clinically now, and a third thing that's kind of on the horizon, but we'll talk about the two things that are available now. So the first is the DAT scan. What a DAT scan is basically it's a dopamine transporter scan. They inject this ioflupane iodine 123 that is taken up in the brain exclusively by dopamine producing cells in the basal ganglia. And so that what we're looking for is either normal or abnormal uptake. It's helpful to differentiate patients if you're kind of hedging your bet on is this a Parkinson's or is this a central tremor? Is this Parkinson's or is this a drug induced Parkinson's? That's where this scan is going to be helpful, but it's not going to, again, definitively diagnose a patient with Parkinson's. This is going to be abnormal in all those atypical Parkinson's syndromes that I mentioned earlier, like multiple systems atrophy, progressive supranuclear palsy, dementia with Lewy bodies. All of those are going to have an abnormal scan. And so when you look at the DAT scan, this is basically what we're looking for. The left is this normal appearance where you can see this comma-shaped uptake of the in the caudate and then down into the putamen. In Parkinson's patients, you typically lose this comma, the tail of the comma first, and then it becomes kind of smaller and more circular. And that's an abnormal scan, meaning there's some type of dopamine depleting issue going on, whether it's idiopathic Parkinson's disease or one of these atypical syndromes. Hard to tell, but at least this kind of pushes you in a direction.
We have another question
Mm-hmm.
from Robert Burrow who says, with Parkinson's, will a patient have a heavy head feeling as well as random dizziness?
That's a good question. So sometimes, yes, but what I would say is sometimes it's important to distinguish what patients mean when they say dizzy, because patients say dizzy and they mean a lot of things like room spinning vertigo, lightheaded, unsteady, off balance. So it's frequent that patients with Parkinson's complain of dizziness because they can have some orthostatic type symptoms. They feel a little bit lightheaded, off balance. They call that dizziness. Generally, patients with Parkinson's are going to feel a little bit off balance, and that's part of the disease. Sometimes they attribute that to this dizziness. This heavy head feeling, sometimes patients will say that, and really what they're saying is like this orthostatics feeling, like they stand up and then they feel off, their head feels heavy, fuzzy, all those kinds of things. So yeah, it can be a part of it. It's usually something else that's causing that, like some part of the Parkinson's, like orthostatic hypotension or something, or gait instability that's causing those feelings. But yes, it can happen.
Another question,
Mm-hmm.
Sharon Cantrell is asking if you're familiar with supranuclear palsy.
Mm-hmm. Yeah, so progressive supranuclear palsy is one of those atypical Parkinsonian syndromes. And basically, when you boil down the atypical syndromes, they're all kind of like we used to call them Parkinson's plus syndromes. So they have features of Parkinson's disease plus something that makes them special, not idiopathic Parkinson's disease. With progressive supranuclear palsy, the big thing there is eye movement abnormalities. So patients have a hard time with vertical gaze. Typically, it's looking down. Their eyes don't move down, and that's due to atrophy in other parts of the brainstem where our eye movement control centers are. It gets a little bit more complicated than that because not every patient with progressive supranuclear palsy has to look Parkinsonian. Sometimes they can look a little bit ataxic, almost like they have a problem with their cerebellum. So it's complex and nuanced, but generally they look like Parkinson's. Plus, they have this profound eye movement abnormality that leads to more falls early on than idiopathic Parkinson's. All right. And then the second thing that is commercially available for patients that we can do in clinic is the SIN1 biopsy. So this is basically a punch biopsy of the skin that we do in the clinic. And it actually looks for a couple things, not necessarily just Parkinson's, but it looks for phosphorylated alpha synuclein, which is the abnormal protein that aggregates in Parkinson's disease. So that's what we would be looking for in our patients. But it also looks at the intraepidermal nerve fiber density. So basically how healthy are the nerves in general, amyloid, and then of course the skin morphology. Like if you go through a mole or something, it'll look at making sure that skin looks healthy and not neoplastic. But the big thing we're looking for in our patients is this phosphorylated alpha synuclein. The skin biopsies in clinic are at 3 sites, along the neck, at the shoulder blade, uh, kind of like that area, the hip, and then down by the ankle. So kind of this general area up here, the hip, and then the ankle. And when you look for all these things in all 3 of those locations. The specificity and sensitivity for this is greater than 95%, so it is helpful. But again, it's kind of like the DAT scan in that there are other diseases that have alpha synuclein pathology, like dementia with Lewy bodies and multiple system atrophy. They're also going to be positive on this. So yes, it helps you get you in the ballpark, but it doesn't necessarily 100% make the diagnosis for you.
Excuse me, Dr.
Mhm.
Ginsky. We have a question. Bridget Dunn is asking, research shows that Black people with PD are diagnosed at a later disease stage than white people. Can you explain why?
Yeah. So a part of that is that Parkinson's is less common in our African American population. So I think it's not the first thing that people think of when they see an African American patient with symptoms of Parkinson's disease. And so things tend to progress a little bit farther until that diagnosis is reached. I think that's a big part of why they're diagnosed at a later stage. And then ultimately sometimes this does boil down to like socioeconomic things and cultural things, like how likely is a person to go to the doctor and work up these symptoms when they first start versus how likely are they to kind of push them off, push them to the side and not go to the doctor. But I think the big thing is that it's just less common in our African American patients, and so it's less often recognized as Parkinson's. All right, looking at clinical rating scales. So I'll just kind of buzz through this because it's not super important. But there are multiple clinical rating scales that we use. The most common is the MDS-UPDRS. So it's the Movement Disorder Society's Unified Parkinson's Disease Rating Scale. It's broken down into multiple parts, and we use this a lot for Parkinson's related research. But part one looks at the non-motor aspects of patients' experiences of daily living. So it's a survey. Some of them are patient answered questions. Some you ask the patient outright and they answer like cognitive impairment. Do they have any type of, psychosis, anxiety, depression, these kinds of things. Part two looks exclusively at the motor aspects of experiences of daily living. So this would be like the tremor, slowness, stiffness, and asking that in a variety of ways. Like, do they have a problem with drooling? How's their chewing? How's their swallowing? How are their movements? That kind of stuff. Part three is the motor exam performed by the clinician or the person doing the rating scale. So we're looking at things like speech, their facial expression, tremor, stiffness, slowness. Part four looks at motor complications that you can see as the disease progresses, like dyskinesias, on-off phenomenon, that kind of stuff. And then you tally that up and they get a total MDS UPDRS score, which is what's mostly reported in the literature in terms of research trials and studies. We also use the modified Hone and Yar scale. I would say this one's a little bit more clinically applicable, and it ranges in stages from 1 through 5, depending on the patient's symptoms and how they're experienced. From unilateral involvement, meaning they only have like stiffness, slowness, tremor on one side of their body, all the way to like wheelchair bound and bedridden unless they require assistance. So that can help kind of put people into categories as well. Again, this is used a lot in research. And then there's also the BRAC staging, which is more of a pathologic staging, where it looks at the amount of kind of Lewy body pathology in the brain and where it's spreading. And then treatment, this is kind of the hallmark of Parkinson's disease and where we're at now. So treatment, we have no disease modifying therapy. So there's nothing that exists out there in the world that will change the course of the disease in general. All of our diseases are aimed at treating the symptoms and making day-to-day life better for patients. Our hallmark is going to be pharmacotherapy or medications, and those fall into a number of different classes. We also have surgical options like deep brain stimulation and focused ultrasound, and then ancillary treatments that are really important for patients as well. So when you look at medications, carbidopa, levodopa is our kind of prototypic. It's the oldest drug that we have that treats Parkinson's symptoms, and it's still the best drug we have to treat Parkinson's. So it's actually a combination of two medications. Levodopa is a dopamine precursor that the body converts to dopamine, which Parkinson's patients are deficient in. Carbidopa is a peripheral decarboxylase inhibitor. So what that means is it basically prevents the outside of the brain breakdown of levodopa into dopamine, so that more levodopa gets into the brain, more levodopa in the brain gets converted to dopamine, and then we're better at treating the symptoms. It also helps with the side effects, mostly nausea, because dopamine is also used pretty significantly in the GI tract. And so by preventing the conversion of levodopa to dopamine in the GI tract, we can prevent the nausea, which is one of the basically rate limiting side effects to using this medication. So carbidopa, levodopa is a big hitter. It's going to reduce the cardinal features like tremor, stiffness, slowness for our patients. What it won't help with is postural issues, so that gait instability, imbalance, it's not going to target directly. Yes, it helps with the slowness and the stiffness, so does walking improve when you're less slow and less stiff? Certainly, but it's not targeting your walking and your balance directly. It is associated with adverse effects, typically nausea, fatigue. It can also worsen orthostatic hypotension in patients that already have it. At higher doses, it can lead to hallucinations. And then kind of as the disease progresses, which is kind of par for the course with Parkinson's, it can also contribute to the development of dyskinesias, or those extra wiggly movements that patients have. Carbidopa levodopa is available in a variety of formulations. There's immediate release, extended release. There's also gel formulation. So Duopa is a pump that goes directly into the GI tract via a PEG J tube into the stomach. Vyalev is the newest formulation. It just came out in like October, November of last year. And this is actually a subcutaneous pump. Looks like an insulin pump, but it contains like that kind of gel formulation of carbidopa levodopa. There's extended release versions of it known as Rytary and Crexont. Divi is a formulation that's easy to split for patients. Parcopa is no longer available in the US, but it was actually a dissolvable tablet of carbidopa levodopa. And then Imbresia is an inhaled formulation. It kind of looks like a little inhaler, and they squirt it in. It releases a powdered formulation of carbidopa levodopa. And we use things like that for like patients who cycle between on and off times, but they don't know when it's going to happen. That inhaled formulation gets in really quick, and then they can get on about their day, like say they're frozen or things like that. Moving on to the next class, so dopamine agonists. These include things like apomorphine, bromocriptine, which is not used all that much, pramipexole, ropinirole, and rotigotine. Again, it acts like carbidopa levodopa without being the dopamine precursor. So it's going to be helpful for those main tremor, stiffness, slowness. But it can also help to fine tune a little bit motor fluctuations that you see with carbidopa levodopa. Because carbidopa levodopa is short acting, its half-life is only a few hours in the body. Patients can kind of yo-yo between being in their on state, meaning symptoms are pretty well controlled, and their off state, they have a lot of Parkinson's symptoms. And dopamine agonists can kind of smooth this out a little bit. Has the same adverse effects: nausea, orthostatic hypotension, fatigue. But more commonly in the dopamine agonist class, you're going to see hallucination, psychosis, and impulse control disorders. So this can get patients into a lot of trouble. It can be simply like shopping, gambling, spending money, but it can also be like sexual impulsivity that can cause a lot of problems in relationships or leading to extramarital affairs, these kinds of things. These generally have longer half-lives and have less of the fluctuations and dyskinesias. The nice thing is that rotigotine is actually available in a patch formulation, so that bypasses the GI system in total if patients are having a lot of nausea. Pramipexole and ropinirole exist in extended release formulations, and then apomorphine, similarly to carbidopa levodopa, is now available in a pump formulation called Anapgo. Glutamate antagonist. So this is one medication that we use. It's called amantadine. And what we use amantadine for technically is to try and reduce dyskinesias in patients. So patients that get very dyskinetic with their medication, have a lot of wiggly movements, we use amantadine to try and block that and turn it down. Amantadine's not the cleanest drug. It has a lot more side effects than some of the other medications, including things like leg swelling, hallucinations, confusion, and also it can cause livedo reticularis, which is that kind of like purple lacy pattern to the skin. That's not necessarily harmful, and it does go away when the medication is stopped, but kind of the rate limiting stuff for amantadine is the hallucinations and confusion. It is available in an extended release formulation known as Gocovri. So that's just once a day, which is nice for patients. Otherwise, they take this with each dose of their carbidopa levodopa. Then there's the anticholinergics, trihexyphenidyl and benztropine. These are great for tremor reduction, particularly in patients who have kind of carbidopa levodopa resistant tremor. But what I will say is these are very rate limited. They're anticholinergic, so they come with all the anticholinergic side effects: dry mouth, nausea, constipation, urinary retention, memory impairment, all of these things. So we try and avoid these in our older Parkinson's patients. They're better for our younger Parkinson's patients. The COMT inhibitors are entacapone and opicapone really here. Entacapone is the most common, and it's actually available in a combination single tablet with carbidopa levodopa known as Stalevo. What we use these for is to reduce off time. It extends the half-life of levodopa in the system, and so patients will get more on time per dose of medication. The bad thing about entacapone is it tends to be has to be taken with each dose of carbidopa levodopa to extend that on time. But opicapone is a once daily kind of it's not long acting, but it's a once daily formulation of the COMT inhibitors, which is great. They don't have a ton of side effects, but they do cause urine discoloration. Typically, the urine turns orange. It's not harmful. It goes away once the medication is stopped, but it's something to let patients know about. But they can cause diarrhea, and in patients that are prone to dyskinesias, you're increasing the longevity of levodopa, so they can get more dyskinesias from this. And then the MAOIs are selegiline and rasagiline. What these can do is they work a little bit like the COMT inhibitors in that they can help to reduce off time or prolong the levodopa effect in the body. They've been thought to be potentially neuroprotective, but that's not quite clear over time. There were older studies that showed that maybe it slowed down the course of the disease, but that hasn't panned out over time. We can use these, especially in young patients or patients that have very little or very mild symptoms of Parkinson's. We tend to use these as monotherapy before starting carbidopa-levodopa. These drugs are also not as clean as carbidopa-levodopa. They can cause issues like hypertensive crisis at high doses, nausea, headache, and insomnia.
Kimberly Desmond has a
Mhm.
question.
Yeah,
What's the difference between PD and MS?
good question. So MS is actually an, a disorder of the brain where you have your immune system abnormally attacks your brain instead of other parts of your body. It is an autoimmune process and it causes plaques in the brain. So these white matter changes that lead to symptoms. The MS plaques or the immune system kind of attacking it, the brain and spinal cord can happen anywhere in the brain. So it can happen in the parts of the brain that lead to Parkinson's disease and cause Parkinson's-like symptoms. It can happen in the parts of the brain that cause tremor and lead to a tremor. It can happen in the back of the brain, the cerebellum, and cause things like ataxia and imbalance. And it can also happen in the spinal cord and cause spinal cord syndromes and symptoms. And so the pathology is different and the presentation is a little bit different. MS tends to occur in kind of these discrete patterns, like an attack, and then patients get a little bit better, and then they have another attack, so on and so forth. All right, and then just briefly, surgical options. So deep brain stimulation is one of the surgical options we offer here at UAB, and this uses electricity in the parts of the brain that we know contribute to Parkinson's symptoms to control symptoms. It's a lead that goes down into the brain, is attached to a connecting wire, and then a battery pack in the chest, similar in size and shape to a pacemaker. Usually I tell my patients to tell anybody that they have a pacemaker for their brain. And it's going to target the same things that carbidopa-levodopa and the dopamine agonist target, so that slowness, stiffness, and tremor. They're also better at targeting things farther away from the body, so tremor in the arm and leg as opposed to like a midline tremor, like a tongue tremor or something like that. And for Parkinson's, we target the internal segment of the globus pallidus and also the subthalamic nucleus.
Jennifer Calder asked,
Mhm.
how often is the deep brain stimulation done?
It's a good question. So here at UAB, we're one of the most populous deep brain stimulation centers in the country. So we do probably on average 3 to 5 deep brain stimulation placements a week. And that's a pretty robust program. But throughout the country, it's done all the time. It's a very common procedure because it doesn't only treat Parkinson's, it also treats essential tremor and dystonia. So it can be used for a lot of things, but it's a fairly common procedure. It used to be seen as kind of like this last ditch effort in treating Parkinson's, but we're trying to change that now in that it's not necessarily last ditch. Tremor sometimes is really hard to treat with medications. And so if patients have tried a couple of medications, the tremor is not very well controlled, deep brain stimulation is really probably going to be beneficial in controlling that tremor. So it's something that's actually done a lot more frequently than it has ever been done in the past. And we keep getting better and better at it, keep getting better and better at hitting our targets on the first pass using all the technology available to us. So it's quite common now. And then ancillary treatments are kind of one of the backbones of treating our Parkinson's patients. So the most important thing is exercise. Exercise is the only thing that we have seen in studies that slows down the progression of disease. We tell patients to target a goal of 150 minutes of exercise per week. And whatever type of exercise they like, that kind of gets their heart pumping, whether that's walking, lifting weights, yoga, Tai Chi, all of these things are super important for patients. Exercise is the one thing I can't prescribe, but that's going to give the best benefit for patients. Also, we utilize our colleagues in physical therapy, occupational therapy, and speech therapy to help us with gait imbalance, all the typical things that we talked about in terms of motor symptoms of Parkinson's. And then also assistive devices for walking. So here on this slide, I have the U-Step walker, which is actually designed by an engineer whose father or mother, I think his father, had Parkinson's. It's a super sturdy walker. It's hard to tip over. It has a bunch of wheels, as you can see. But above and beyond that, it's not like the typical rollator. You actually have to squeeze the handle to make it go. So it's it's in the brake mode unless you're squeezing the handle to make it go. So it doesn't kind of get far away from people, which leads to falls. It also has a sound, like a metronome, and a little laser pointer that can be helpful in patients who have a lot of freezing of gait to help them walk and get going. So this is very handy. It's also relatively expensive. As you can see, I took this picture off Amazon. On Amazon, it was like $630 or something. But usually we can get insurance to pay for it. And then Rocksteady Boxing is one of the programs that you can find throughout the United States for Parkinson's, and it is a combination of boxing. It helps Parkinson's patients with their balance, tremor, stiffness, slowness, all of these things. And it's specifically designed for Parkinson's patients. Here in the Birmingham area, there's also PD Fight Club, which is run by Martin Juarez. He was a Rocksteady boxing coach, but he wanted to add to it and modify it a little bit. So he does PD Fight Club, which is also really great. The thing that he does that's a little bit different than Rocksteady boxing is he also incorporates memory games to help target the cognition, which can be a problem in Parkinson's patients. But Rocksteady boxing is found across the United States, and patients really enjoy it. It's a way to be involved, stay active, get your weekly daily exercise, but also be involved in a community of people that understand what you're going through. And then, of course, there are ways to treat the complications that we see with Parkinson's disease. So the biggest one is psychosis. Nuplazid is a medication that's been specifically approved to treat Parkinson's-related psychosis. And it's great for our Parkinson's patients. It's only a once-a-day dosing. It's a one-size-fits-all dosing, which is really nice for them. The big thing is it causes QT prolongation, so they have to be worked up from a cardiac perspective to make sure they don't have a prolonged QT to begin with. We can also use the standard atypical antipsychotics, but those are dopamine depleting agents and they can worsen our Parkinson's symptoms. So the development of pimavanserin has really changed the game for Parkinson's patients. Also, things like treating orthostatic hypotension, it's pretty routine in terms of how we treat orthostatic hypotension in all comers, things like fludrocortisone, droxidopa, midodrine, compression stockings. But you can also use pyridostigmine in Parkinson's patients, and they have pretty good effect with that.
Ms. Polk
Treat
added
Yeah,
to what you were saying. She
yeah.
says, Heather Polk, some of the YMCAs in Birmingham have a great Parkinson's program available to the community. They also have exercise classes specifically targeted for patients with Parkinson's. And then also, I know of at Lakeshore Foundation, there is a Mark Morris dance company regimen that is supposed to be very good.
Yeah, the Birmingham community has a lot of support for these patients. And sometimes at the YMCAs, I know some of my colleagues go and speak at some of these support groups and stuff too. So it's really a great program. Okay, and then to round out, so patients with Parkinson's can also develop dystonia. That's where we use botulinum toxin or Botox. And then treating depression and anxiety is pretty standard, par for the course. Typical treatments of anxiety and depression in all comers, like our SSRIs, SNRIs, so on and so forth. And that kind of rounds out the whirlwind of Parkinson's. It's kind of complicated. There's a lot going on in Parkinson's, and I could probably talk about an hour on like each separate thing I talked about, but I tried to put it all together and condense it as best I can for y'all.
Well, you did an amazing job. It was a lot of information, but covered very thoroughly and simple enough for someone like me to understand, which is quite simple. We appreciate the effort and the time that you put into this presentation and in giving it today. I will read, we've extended past our hour. I'll read again real quick the evaluation link for those on YouTube who aren't seeing the screen. It's https://surveymonkey.com/lowercase r/ all uppercase letters and numbers 53D as in dog XRYH. And the password today is pathology. Thank you all for being here. Thank you again, Dr. Roginsky. You were really phenomenal. We've got some comments, great presentation. Thank you for your time and energy. Wow, I learned a lot. So informative. We really appreciate you, Dr. Roginsky, the work that you do with Parkinson's patients. And we hope to have you back again soon to join us. I'd love to hear more about the deep brain stimulation. As we were discussing, I have a friend who's recently been through that, and I'd like to know more about it. So maybe we can have you back.
Absolutely. I'm happy to be here anytime.
Thank you. Y'all have a great week. Join us again July 14th. That's a Monday. We'll prevent supervision. So we'll have a supervisory CEU. Today's is clinical. Thank you, Dr. Roginsky. Thank you all for being here. Y'all have a great couple of weeks.